had higher error rates at 6 weeks. So when we take all those types of improvements, I wanted to pictorially show you where those improvements bridge and why we pursue a multi-solution approach, especially with technology, to build a safety system. CPOE really helps with medication and transcribing. You could even argue that it really helps with that monitoring component as well, because of the fact that it does free up pharmacists' time to meet that need. IV workflow and carousels, as well as barcoding, can really help dispensing. As far as administering, the two most powerful tools, especially at the inpatient level, are going to be your smart pumps and barcodes at bedside. So nurses can actually scan medication at bedside prior to administering it. They can also scan the patient armband, which contains their patient identifier number as well. Make sure that we have the right patient and the right medication dose, and connecting to an electronic health record so that we have the right time as well. Electronic health records have been the largest impact to enhance monitoring of our patients, because of the fact that not only do we have all this data readily available to us at any time in one place, but on top of that, we're able to now analyze that discrete data as well and look for trends in various clinical markers for individual patients. And this is just a powerful tool to be used. Kind of bottling all of these things, what does the Institute of Medicine in particular recommend as far as decreasing the likelihood of medication errors? So I've listed that here for you. So really, and probably the most important thing, is to monitor medical literature for new drug info. Like what types of errors are happening now, since we do have new drugs hit the market, new practices, new guidelines coming out what almost seems on a daily basis. It's so important that we stay on top of the likelihood of errors as well. The best way I've heard this put is that in order to be good safety stewards for our patients, we must be preoccupied with system failure. And there's no other way to put that. That preoccupation with failure, while it may seem like a negative approach, will ensure that we're always waiting for the mistake to happen. Because, and I'm sure you're beleaguered with me saying this, errors really are a matter of when, not a matter of if. Every member of your class will make some sort of medication error, and the question is how will that be handled, and do you have the processes in place to reduce the impact on your patients? Verify accuracy of prescription order entries. So with the advent of CPOE comes a little bit of issue as far as making sure that defaults weren't selected because they're defaults. They actually were what the prescriber intended. More on that in a sec. It's also important that facilities, and this could be community pharmacies, could be hospital pharmacies, that you closely monitor the frequency and types of errors, and most importantly, your near misses. If you think back to the pyramid we talked about in the last session, it is so incredibly critical that we keep track of near misses, because near misses are how we prevent the serious safety event from happening. Use of barcodes for patient identifiers, as I mentioned earlier. One of the things that we've never, as pharmacists, we can always be better advocates in general, and one of the things we need to do better, or that we can do better, we actually do it quite well, but that we can do better and should do better, is to educate stakeholders about error prevention. Who are our stakeholders? Our stakeholders are our patients, our providers and physicians. They're the nurses that administer medications, basically anybody that touches that medication use system. Use of electronic prescribing tools when possible. Errors are always enhanced with poor handwriting, or having to handwrite at all, because fields are sometimes omitted, and then we are forced to make decisions for our providers. Develop methods to monitor pharmacy technology to avoid errors. Just because it's technology and somebody says it's safe doesn't mean that it's going to improve patient safety. Sometimes technology can actually worsen patient safety if not implemented correctly. So it's important that we monitor the types of errors that occur from technology. One of the universal truths of technology is that it fails. And so monitoring the incidence of technology failure is absolutely critical in keeping our patients safe. with technology, we're seeing a whole new host of errors, and there's not as much data on this yet because technology as a universal concept in healthcare is kind of recent, especially as it pertains to medication safety. Um, Even something as simple as barcoding really didn't come into vogue until the mid 2000s. And so a lot of the innovations that we have are exactly that. They're innovations, they're new. So we haven't even scratched the surface on all the things that can and will go wrong. One of the biggest concerns as we move more permanently towards electronic health records is the concept of downtime. And so we still need to be sure that in medical schools, nursing schools, and pharmacy schools that we're teaching those that prescribe how to write orders without the use of an electronic health record, how to include the right dose, the right drug, and assuring that we have the correct patient, how to transcribe correctly and use the appropriate abbreviations. And so as we become more and more comfortable with electronic health records, and as we graduate more students that have never known the paper world of healthcare, downtime becomes a very dangerous period. So that whenever our electronic health records are out of service, bad things can happen. And so it's important that we really treat those downtime periods and train our healthcare providers and personnel to be ready for them. The other obvious risk is going to be a dependence on safeguards. And so a lot of times I've seen people get way too comfortable with the fact that, okay, well, the computer is just going to catch the drug interaction, so I don't need to review the medication profile. And that type of dependence on those safeguards is very dangerous because you've essentially told the computer to be your clinical decision maker instead of you. And you have to remember that it is a person that programs those safeguards, and they, just like you, are fallible. And so it's important to keep those people just as honest as they are keeping you honest, and make sure that safeguards are appropriate, that they are accurate, and that they are relevant. One of the things we see with CPOE especially is a failure to correct default settings. So a lot of times to remove barriers to CPOE, because many providers were very resistant to CPOE because of the fact that it was going to increase their workload, or there was a perception that it would increase workload rather, was to set default settings so that whenever I order acetaminophen, it'll automatically, for example, it would automatically come up as 500 milligrams Q6 hours PRN pain. And although that's a pretty relatively innocuous drug compared to other things given in the hospital, if I was ordering that drug for fever but I didn't change the default settings, then they don't have a medication that's there to cover for fever, if that makes sense. Also, there's kind of been this interesting culture that's developed on how to handle ordering errors from the pharmacy perspective. So if something was ordered wrong on paper, it was usually pretty obvious. It really stood out as obvious. But since we've created these safeguards, and instead of free texting doses, now we have buttons you can click for the dose, now we kind of have to play psychic from the pharmacy end and decide, did the physician or nurse practitioner or whoever ordered it, did they really need to click that dose? Or did they click it because they thought it was right? And then how do you handle that? Is it okay for me to just change it to the correct dose, or do I need to call the provider? Obviously, the answer when you put it that way is to call the provider, but you'd be surprised how gray this category of concern can get. Also, even though the idea of having health records readily accessible any place, anytime, there's a little bit of a drawback. In the paper charting world, if Dr. Jones was writing orders, there was only one place he could write orders, and that was at the patient's chart by the patient's room. And now, if you see orders come across your electronic health record, you may call the nursing floor and ask for Dr. Jones, and they say, well, Dr. Jones isn't here. And so one of the things that we've kind of seen, unfortunately, is that providers will order medications without touching the patient. And we've even seen where physicians would enter admission orders without ever seeing the patient. And so they're going entirely based off what's in that electronic chart. And so it's a very dangerous thing, because it removes that barrier. Essentially, I like to say that it's good to have processes that help good people make good decisions, whereas this helps good people make bad decisions and enter orders without really evaluating their patient, or there's an opportunity to. It doesn't happen often, and I'm definitely not trying to disparage any particular profession or point a finger, but it is something that unfortunately does happen. Lastly, and probably the most important, and there's probably more and more body of evidence coming out on this, and that is this concept of alert fatigue. And so this has happened for many years with patient alarms. So those of you that have been on nursing units, you'll hear bed alarms going off, you'll hear nurse call buttons going off and all that. And you'll see the staff is very comfortable with it, probably a little too comfortable. And it may even bother you because you're like, man, I would have responded to that like right away. But there's this concept of alert fatigue where eventually you kind of get a little numb to the alerts that happen. Pharmacists are just now getting exposed to that with clinical decision support. So what do we mean by clinical decision support? Well, whenever we have CPOE and we have physicians inputting medication, then it comes across to us to verify that medication's accuracy. We have an entire pop-up of the drug interactions and food interactions and contraindications, et cetera, et cetera. The problem with clinical decision support systems is that they are exactly that. They are there to support decisions, not make them. And so as a result, the pop-ups that come up on this, you'll have every drug interaction in the book will pop up, even those that are really clinically insignificant for your patient. And it's up to you as the pharmacist to decide if those interactions or that contraindication is important enough to make the call to the physician, or if in your professional judgment they're insignificant. The problem is that a lot of these interactions, because these systems are designed to be all-encompassing, there are far more insignificant interactions than there are relevant interactions. And so as a result, many of our pharmacist colleagues have gotten all too comfortable with clicking through these screens without really reviewing them. And so it essentially removes the value of the clinical decision support because of the fact that we get that alert fatigue. We just get used to breezing through them because they usually don't have anything of value. And so then we miss that critical alert that comes through that may save a patient's life.